Hi, Mike Gibson, Steve Nissen here, and we're talking about an update to the guidelines. Steve, there's been a lot of changes in the guidelines. Where do non-statin therapies fit into the updated guidelines?
Well, first of all, I'm very pleased with the new guidelines. They're really much more thoughtful, and I think, go in the direction that I was hoping that they would go in, which is toward lower target levels for LDL cholesterol for many people. And in the guidelines, they repeatedly bring up the issue of non-statin therapy. I actually looked, interestingly enough, just to see how often. And non-statin therapies are actually mentioned 87 times in the new guidelines.
Wow.
And the reason, of course, is the understanding that there are two issues. One is that there are a lot of people who don't get to the LDL goals, the more aggressive LDL goals advocated by the new guidelines, and they need additional therapy. And, they mention all of the additional therapies that are available, including ezetimibe, PCSK9 inhibitors, and bempedoic acid. And I was also pleased that they repeatedly cite, our study of bempedoic acid, which the Clear Outcomes trial, which showed, a very nice statistically significant reduction in major adverse cardiovascular events in both secondary and primary prevention. And one of the most striking things I think about the study is the manuscript, the secondary manuscript in JAMA, which showed about a 30% reduction in morbidity, in the morbid outcomes for primary prevention patients. And that's was really very striking to us. So they're really talking here about trying to achieve very low levels, and they have a variety of classifications. But for example, in FH, they have a class 1 indication for additional non-statin therapies, including PCSK9 inhibitors, ezetimibe, and bempedoic acid. And in primary prevention in patients, these patients with very high LDLs, they recommend getting to below 100 milligrams per deciliter. And you really can't do that with a statin alone. So that's the kind of the big picture here. And I think it's a step in the right direction. And it kind of pushes the medical community to be more intensive about using a variety of therapies, including non-statin therapies.
An earlier initiation as well, Steve. I mean, screening people a little earlier in their life, not only is lower better, but perhaps longer is better.
That it's very clear here. And again, I was hoping that we would see something like this in the new guidelines. Um, I think you and I probably are also been aligned on this issue for many years that um, if you really look at the calculators, the prevent calculator, really you don't rise to a high level of risk until you're older. But what really counts is not short-term risk, it's lifetime risk.
Correct.
And we have known for many years that the time averaged LDL cholesterol over the lifetime of a patient is a very strong, maybe the strongest predictor of whether or not they're going to have an event. And so if you wait until their risk is high, you lose the opportunity. And there's a subtlety here that's very important. And the subtlety is that if you start earlier, you may not have to go as low because you have the advantage of time. And so you can use, lower doses. One of the things that is addressed, by the way, with regard to non-statin therapy are the patients that have statin associated symptoms, side effects that are not tolerable to them. And I think most people who practice medicine and who see these patients know that regardless of the controversies, about statin intolerance, that statin intolerance does in fact exist, that it's not terribly uncommon, that it may be absolute or relative. So, some patients who need high intensity statin therapy won't tolerate it, but they might tolerate an entry dose of statins. And that's, I think, where non-statin therapies really have advantages because you can take a low dose of statin, you can add ezetimibe, you can add bempedoic acid, and if you absolutely have to, you can add a more effective, PCSK9 inhibitor, but you can get them where they need to be. Now, it's important with regard to these therapies that what we get from ezetimibe is about an 18 or 20% additional lowering. We get about a 20 to 22% additional lowering typically with bempedoic acid. But interestingly enough, if you combine ezetimibe and bempedoic acid, the guidelines cite the very good literature that suggests about a 38% reduction. Well, if you think about that, that's equivalent to a moderate intensity statin. That's equivalent to about 40 milligrams of simvastatin. And so, for these very difficult to treat patients with statin intolerance, a variety of non-statin therapies can be used, and including an entirely oral regimen, which is ezetimibe and bempedoic acid, or if necessary, an injectable regimen that includes the various PCSK9 inhibitors.
Well, it's clear lower is better. I think we all agree on that. I'm thankful we have a lot of tools to get there. Thanks, Steve, for joining us.
And thank you for having me.